So we're continuing our discussion on digital twins. Today we will be talking about the application of this approach to digital metabolic twin, the center developed in Ireland, and especially the work on virtual metabolic human that will give us an insight how this research is translated into practical solutions. So Cyrille, would you like to tell us a little bit more about yourself?
My name is Cyrille Tinnis. I am a research fellow and engagement manager for the Virtual Metabolic Human here at the University of Galway. I am working at the Digital Metabolic Twin Centre, and I'm part of the team of Professor Ines Thiele in the Molecular Systems Physiology group.
Right. So this is your journey. Why did you decide that digital metabolic twin is something that you want to invest your time and resources?
I think there's a couple of things going on. So I had a very basic fundamental research grounding. And then at some stage in your journey, you kind of ask yourself, what's the next big thing that's happening in science throughout? And then I think about a decade ago, data science really started coming in. So lots of sensors were developed. There was the genomic revolution. So all the omics technologies started being created. And a lot of the things that used to be more, call it science fiction, a decade ago, they become very mainstream. And by mainstream, I also mean they became more ubiquitous because they became more available, they became cheaper. And then you sit on loads of data overall. And I think like engineering or even social media or so, they capture everything they can get their hands on, but it's just data sitting around. But people didn't really know what to do with it. So suddenly there was that moment in time where we had lots of data, and specifically in my case now health data. And on the other side, I could see parallels with my fundamental research that we've been doing. There might be new things we can then elaborate. And then from engineering, again, there's been the concepts of digital twins. So that was something I found very, very interesting. And then somebody told me about digital metabolic twins. And I thought, well, now is the time to invest my time and expertise to hopefully find an environment where we can do the next big thing. So really, when you start off as an undergraduate or even as a PhD student, you have these opportunities of learning, but then you ask yourself, what's the next thing we can do? And I think now, in terms of metabolism, digital metabolic twins, it's just something where the time is right, and it's something I'm personally very interested in as well.
Yes, the time is really right. Everybody's talking about longevity and, staying healthy for longer than, the biological span. I listened to your video that I found online. And at the end you said, oh, it would be like having in your pocket a real coach that will, advise you on your health in a real time. Is that the goal?
Absolutely. I think historically speaking, healthcare was based on authority. There's something maybe wrong with you, you have symptoms, and then you go to that authority, which, might be the doctor, which may be the healthcare professional. And you kind of at the grace of their decision making, and whatever they tell you, you hope that somehow it's helpful, and sometimes it's not. So you have to go back and, you slowly and surely working out, hopefully, what may help you. And I think that's changing now, because if you have a coaching approach, I am part of that decision-making process. So it's more of a collaboration, a conversation, or even a dialogue where, I tell them what is important to me, how I'm feeling longitudinally. So it's not just that 5 minutes in the practice, they say me. And, worst case scenario is at that very 5 minutes I'm seeing them, I'm feeling absolutely fine. And then I'm driving back home and, my condition deteriorates. So there's really that opportunity to have that conversation, backed up by the data that might have been collected through my phone. It has a step track on there. I'm currently wearing a fitness tracker as well. So, you have other data that's longitudinally collected, and then really have that conversation together with somebody who still has their authority. But I think I feel more like an equal almost to really feed into the decision-making process. So I'm not just a narrator of my own condition, but I really become somebody who's actively contributing to making that data-driven and evidence-based decision to help myself. And that's incredibly empowering, I feel.
Yeah, I can see that trend, and I also see that people use generative AI to kind of diagnose themselves, and they feel that this might not be right, but it's very tempting to try out different methods. But what you're proposing is not generative AI, it's more mechanistic models, isn't it? Would you tell a little bit how it's designed in comparison to black box, which is AI?
Yeah. Well, you say it exactly. A black box AI, you don't know what's happening behind that black box. So very confidently, that generative AI just tells me a story that's plausible based on words alone. And that's very dangerous because the confidence and, the assumption that AI may help me is a very dangerous recipe to make the wrong decisions that are not really pertinent to myself. Worst case scenario, you might be manipulated into some sort of wrong decision making. So I'm not a proponent of generative black box AI whatsoever. In terms of mechanistic modeling, the scenario is very, very different. So the way these models are usually built is they're being built from the bottom up. So you go out into the scientific literature and you see what is validated. What have people seen and done and validated before that is more true than, say, black box reasoning? And then you build that up. And then usually what you end up with is a generic model. But then I come in with my own data or the patient's data. Then we can personalize that generic model. So we go from a generic human model to, say, in terms of metabolism, we can now personalize that metabolic modeling that's correct in the general human sense, but now it's relevant to myself. And then because everything has been validated throughout, because all the data has come from the scientific literature overall, what we can then do is ask the model different scenarios. And, if these scenarios are kind of cohesive throughout, it again gives us confidence that the model is leading us into the correct direction. And, worst case scenario, there might be like very, very disjointed answers you get, but then that's tells me already maybe the model I'm currently using is not 100% accurate for answering the question that's very specific at my moment. So already you can see it's more maybe like a traffic lighting system. If I have lots of confidence, I do have that validation and verification mechanism inbuilt into my model, and I can give it more confidence. On the other side, if there's lots of random things that are popping up throughout my decision making using the model, I might already be more cautious. And then again, you need that human in the loop. You still need that kind of your own critical thinking as a collaboration with the model to help you out throughout. So overall, I would say, black box AI, very, very dangerous ground for making medical decisions. If you have a mechanistic model, you can have lots of confidence. However, already within the model, there's stop and go mechanisms inbuilt where you can say, okay, maybe in that specific case, I might be more cautious.
Right. So the model is built because you can interpret very different data, right? That is being incorporated by the model. What kind of data is needed to make the metabolic digital twin kind of like a foundation model, let's say, and then fine tune it or change it so it matches specific individual metabolic model?
Like many, many, many years ago, the first kind of models that came up, I think, were very simple models. They were even called core models of like single bacteria. There's like an E. coli core model. And the way it was built is you start from the gene sequencing and then you figure out what are the metabolic reactions from the gene sequencing. And then you build that basic model. And although it was very, very reduced, the core model, you could already see under what conditions does my microbe grow and under what conditions, for example, under oxygen or without oxygen, has it better conditions of growing. So although it wasn't comprehensive, already I could ask it very specific questions and it could give me a very helpful answer at that stage. So that's very, very basic. A human is much, much more complicated throughout. So I think the genetic data, the ability to do genome sequencing at the human level was really, really an accelerator
Breakthrough.
for building digital metabolic twins of humans. But then the human part is not my only part. So there's Cyrille, the human parts, and you're never alone. So you've got trillions of microbes living inside you, like in your guts might be the most famous, but they also live in my nose, on my skin, everywhere, really. So there's an interplay between my human parts and my microbiome part. So the next big thing really was to move from these single microbes that have been built models of many, many years ago to really assess what are the communities of microbes living on and, inside me. And one advancement really was the first resource that had many, many different microbes. So in our lab, we built Agora that has 818 different microbes. That was the first large-scale resource that we built. And that was already helping us to build a community model of your gut. And then we had the microbes, the human part, but then you also need to build the methods so we can simulate how do they talk to each other. How does for example, when I eat something, when it goes through my digestive tracts, how does it end up metabolically with my microbes? Then what do the microbes do with those metaboloids and how do they come back into my human part? So that interplay needed to be simulated. And then, of course, we started growing and expanding the microbe source throughout the years. So Agora was the first resource, 818 microbes. Then I think 2 years ago, we built Agora 2. We were at 7,302 microbes, so a factor of 10. And now this year we released Apollo. And Apollo is a very pertinent name because we almost at 250,000 microbes now. So we're building up the resources that are relevant, the human parts, the microbe parts, but then we also depend on other sources that affect metabolism, like our nutrition. So we build a nutrition part. There's the environment. So we're currently looking into, are there any chemicals we might be in contact with throughout our life course that we might also consider incorporating into the models. Medication is a very big topic, of course. You take medications, they have an influence on your metabolism. So it's a matter of building the resources to be able to do the modeling, but then also can we have the methods to operationalize the modeling. And then, I'm just talking to you through a computer. Computer power has become bigger and bigger throughout the years because the models, I told you, the human parts, the micro part, 250,000 microbes, environment. And so, computing power needs to help us out to handle these large scale models. So really it's a systems approach towards building these twins.
Yeah, so for me, this is very important because it shifts the way we see human life and also diseases, not as one single, very particular case, but in a systematic way that translates this complexity of different, microbiota, different conditions that are external to our body, and then gives us opportunity to see again more holistically a person, right? So the lens that you are applying, which is metabolism, it takes this complexity and then shows not single functions, but the whole systemic, let's say, picture. What do you think would be the most important application? You mentioned how metabolism is performing when people are taking drugs, for example. So it might affect how drugs are useful to a certain extent to certain individuals. Any other examples you think that would be something that we need as society?
Yeah, I think these mechanistic models really help us move towards precision medicine. We are still talking about one size fits all in our current health systems. So very often that's statistics driven, and statistics is based on correlation. So we can, for example, say a BMI correlates with cardiovascular disease, type 2 diabetes, cancer, and all these kind of things. But we don't really know what are the steps involved at an individual personal level to have that correlation be true or not be true, and then how can we interact and intervene. So that's one thing. On the other side, having that precision medicine approach, I think what I'm personally very interested in is the power of making predictions. Because very often you might say, we are currently not doing healthcare, we're doing sick care. Most people only go and see a doctor when there's already something happening. You already see symptoms. But if I have a symptom, something has already gone wrong in that trajectory from me going healthy towards having a symptom. And many, many diseases, people tell you the earlier you intervene, the bigger are the chances that you can actually find a cure fast. So with that in mind, would it be possible to make predictions that already tell me, without having any symptoms, Cyrille, these kind of things are starting to get out of whack, out of balance? We recommend you go see somebody and already have the health tests or the blood tests or whatever you need to do done way before, let's call it, too late, before something has already happened to me.
And those predictions, when you saying this word, I'm very curious, what's your view on how and when to deliver this information to a person that is not yet a patient, but has got high risk of becoming ill or, they bear the consequences of certain choices in their lives. How do you see this? What would be the best way to allow person to access this information when it's still a prediction, and how that should be delivered so we are not scaring the patient and causing, psychological issues, but something that is helpful?
Yeah, I think the opportunity of empowerment is becoming very, very important here. And I think in terms of that collaborative decision making, I think that's the question we can already ask the person. How would you like to have that decision making process done with you? Because maybe some people, they don't want to be involved. They just say, whatever happens, happens. I do not want to know if I'm higher risk for certain things because maybe it's not true. And now I'm going down a rabbit hole and, it's going to ruin my life. So some people may just not want to know, and we have to respect that. And that's the best scenario for them, maybe. Other people, they might be the complete opposite. They might say, oh, I want to be involved in every single step. And, they might have a tendency, let's call it, to micromanage their condition. But if that's what they want, be my guest and let's have them involved. Like some people, they wear 5 different trackers. They want to know everything. And they ask their Garmin first thing in the morning, how was my sleep? So I think people have, they can already be involved in the process of how they want to be involved in the process. And that's part of empowerment. So I think already there, we had a very personalized approach. This being said, what you don't know, you don't know. Because maybe I feel like I really want to be involved, and down the line I feel like maybe I want to have somebody else guide me, or the other way around, I say I don't want to be involved, and then over time I learn to appreciate how much my own decision making can actually help people help me. So I think there's a very, very fine balance to be struck. I think people need to be involved in deciding how they want to be involved, and at the same stage we need to be able to provide that flexibility for people to also change their position throughout that decision-making process throughout. And I think there's some areas we can learn from. For example, in genetic counseling, there's very specific jobs where people are trained. If some people have done genetic testing for whatever reason, if they find a mutation that actually puts them at a very high likelihood of developing a certain condition, those people are trained on a scientific level in terms of scientific risk making. So I don't want to tell you you're at a high risk when actually the risk is not that high. So that's bad. So those people are trained scientifically, they're trained usually medically, and they also have psychological and counseling training to make those decisions. So I think we can learn lots of them. And maybe now there's a new job being created in the future of having somebody like a health counselor.
Mm-hmm. Yeah, definitely. No, it sounds like that. I'm also curious. So if I am able to get this information and make changes, would the model adapt? Because, I'm also making some choices and I'm changing my life. Would that be visible and kind of motivate me to even go further and change more things for better?
Yeah, I think it depends on the model, of course. Some models are very flexible and some others, they may not be. I think in terms of the fields, how we're moving, it's all about having that longitudinal integration, which means we can change the model in a dynamic way over time. And you can see how health data is kind of collected. So, for example, my activity levels, my health tracker can track because it logs my steps, it logs my heart rate, it logs my workout. So that's kind of an easy way to integrate that. However, on the other side, something like blood tests or so, that's a lot more difficult because, only maybe every couple of months or even years in some cases, you might get a blood test. So the question is, are we able to co-create technologies that are enabling my models over time? For example, you might have a continuous metabolic platform measuring different metabolites on my arm. That doesn't really exist at the moment. It would also be very impractical. Like people with diabetes, for example, they can measure their blood glucose continuously. However, it's not measuring blood glucose, but it's measuring other molecules that are surrogates for then making an approximation of the blood glucose level. So at the metabolic level, I think it's something we'd be striving to in the future, to have like continuous integration of your data. I think practically at this very moment in time, it is not really. So, you might update your model every couple of months whenever you're getting new tests done in a blood laboratory, for example. But I think the way the field is moving, having that continuous integration, I think that's where we're going towards in the future.
Yeah. And when you're talking about empowerment, we need to mention patients. You are also involved in public and patient involvement activities. How does that go, and how you envision that involvement to be beneficial for precision medicine?
Yeah, so a mantra that really struck with me was nothing about us without us, which is often told by the patients. So they don't want somebody making decisions about their health, and they haven't really been involved. And that was something I learned about when I moved to Galway in 2019, because public and patient involvement was a big program that already started here at the institution and was very, very advanced already at a clinical level. So clinical studies would already work together with patients to co-design the studies. So it wasn't just like, oh, please be a participant in our study and we take all your data and we tell you afterwards how the study went. But it was really about, how can we design the study to answer the questions that matter to you. And to give you an example, in clinical studies, for example, the endpoint, so what you're measuring, often is a biomarker. So that's something in your blood. But that biomarker, which is a molecule, does not necessarily correlate with the quality of life. So, can we measure things in our clinical study that have a perceptible impacts on a patient life? And having somebody make these decisions who has no idea about what it is like to live with a certain condition is a very crude approximation, I would argue, in a diplomatic manner. So having patients already involved in that decision making, I think, can really augment how we conduct science and clinical studies. So clinical area has been very advanced, but then being very critically reflective about what I'm doing in the lab every day, I have never talked to a patient when I'm creating my models here. So in a sense, I felt like preclinical, especially computational research, was very, very underdeveloped in terms of public and patient involvement. So there was something aspirational to strive towards working in the future. But on the other side, there's also a huge risk, because if the clinical area already does it and we're not doing it, that means we're missing out. So there's lots of opportunities that we're just missing out in terms of doing better science. And then there's been external motivators as well. Like overall, if your study fails, you kind of wasted lots of money. Some funders started asking for public and patient involvement as an inclusion criterion to be eligible for funding. So if we're not doing it, we have a hard time being competitive with people who already do it. And that was one of the motivations, really, to create the initiative of having a dedicated public and patient involvement working group within the Avicenna Alliance, which combines academic and industrial stakeholders together. And over the time, we also recognize, it's very underdeveloped in silico medicine overall. Well, it was 5 years ago, but really having that conversation about advocacy, make people aware it exists, because you can't bring in change if people don't know what you're trying to change. And then also helping people of how to implement it. What can you do specifically to consider public and patient involvement in your studies, and what are certain frameworks, certain toolkits, how do you interact with, say, a patient organization, what is the value for them, what is the value for us, and have really that collaboration at that level to make better science in the future, hopefully.
I absolutely agree. I think that this is such an important issue that, patients are not involved or involved only a little bit at the very end, for example, as end users. But understanding their point of view, for me, it's important also to see the problem through their lens, right, through their experience. And that tends to push then work towards better understanding of a problem rather than jumping into making solutions, which might not be adopted, because then you don't have a user who will agree that this is something that brings the value, because you didn't understand the need at the very beginning. But there is also a huge challenge involving patients. Any kind of advice or any experience that you could share how you involving patients? Is it focus groups? Is it like, discussions? What do you do, or what would you recommend to use?
Yeah, I think it really depends on a case-by-case basis. And I think your involvement already starts when you're planning your involvement. So a good way forward usually is to contact a representative association. So if you have a patient organization in your area, ask them, do you see value in being involved in the first place? Because if you map out, say, the life cycle of a research project from the very, very beginning to the very, very end, very likely there's no value to be involved throughout all the stages throughout, because it might also be, you cannot implement it at that scale. So to really already ask them, where do you see value specifically, and maybe already rank it throughout? And then how would you prefer to be involved in the first place? And I think that's already helping us map out together with them what's the best way forward. Because in some instances, you might be best off having a one-on-one dialogue with, say, a representative of the association, and they can speak on behalf of their members throughout. And that's a very efficient way of having that involvement. However, sometimes, it might be a very personal experience of living with a certain condition, even though they might have the same diagnosis. So you might be better off working with different people, either individually or maybe having more of a group session. And there's many different ways of how you can facilitate that. It might be a World Cafe type of scenario. It might be a workshop. It might be something else. And really work with them as well of, what's the best way to involve us. And sometimes it might be very operational as well. Maybe sometimes it might be in the west of Ireland, and some people live like very remotely. So just having them come in and drive an hour to come, say, to campus of the university, or the other way around, to have the researcher drive out 2 hours to go and meet them somewhere else, might already be barrier enough to make it very difficult. So I'd say, how would you like to be involved is a very important question to already work out together with representatives. And then that also brings us in, you need to be able to find a balance between representation. So, do you get the data you need with the people you want to have the best study you can possibly design, versus maybe bringing in a certain type of, let's call it bias, where some people might steer the decision making in a certain direction that's very subjective, and then you might have somebody else who says, well, that's not really my experience, but I have been quiet throughout the process. And then you might have some sort of interpersonal challenges to work out in terms of bringing back the representation. So I think it's very complicated, but it has lots of opportunities. And from my perspective as a computational biologist at this moment, we can learn a lot from the clinical study environments and community, because they've done many things and they're very happy to share. So they will tell you very often, this worked perfectly in our case. We tried, it sounded good, but it wasn't great in the end, to hopefully have it as a learning process as well and find inspiration.
Yeah. Let's talk about your team and people who are involved in projects with you. I know also that you're doing lots of involvement from student side. So would you tell us a little bit more about that?
Yeah. So on one side, what I wanted to do was to find a strategic angle towards the whole involvement and engaging with people. Because very often what you find in my environment is people feel like they have a mandate that's given by an external factor, like a funding body, and then they just start ticking off things like, I've done a workshop, I've done a podcast, I've done a press release, end of story, don't talk to me anymore. And I think we're having an issue of, being valuable, genuine, and really make it work throughout. So I was very happy when Ines Tida, I'm working with, offered me to have the position of engagement manager, to really have it as one of the core pillars of my position, to really help us, let's call it diversify potential beneficiaries of what we're doing in terms of computational modeling, and to flip it around, how can we accelerate the positive impact of what we're doing in the lab? And there's a couple of questions I had in my mind. And one is, we've done all our resources. We went through the data we have. So we have, for example, a virtual metabolic human, which connects all the different technologies we have already done and gives them in an open access manner to the community. But then when we looked at the data, it seemed like the community is other computational biologists that do something very, very similar to us. So, that's kind of translation into impact wasn't really there, although everything was accessible for free. So the next step really was to ask, who are people most likely to use our technology? So we did a stakeholder mapping throughout. And one thing that we recognized really early is that the computational biology community is relatively niche. So if you're scientists of the scientific community, computational biology is a tiny, tiny, tiny part of them. And then we ask ourselves, why is that the case? Because clearly we're very biased. Our technologies have value towards the greater scientific community. And one of the things we recognized was that undergraduate students, for example, they tend to gravitate towards areas they've seen during their curriculum. So if you've seen area X with Professor Y, you are very likely to pick up that area with that professor because you heard from that particular thing before. So we thought, how can we elevate the profile of computational biology throughout the undergraduate curriculum? So we had our new user group, undergraduates. And then we also recognized that undergraduates, what do they do in the summer? Well, they either go into let's call it an everyday job to earn some money for their studies. So they might work in a supermarket or so, or they do research in an area they already know. So we thought, okay, can we create something that's valuable to them in an area that's important to us, so computational biology. So what do they want? So I actually talked to the career service, and they told us, well, people, they want to have exposure to new techniques. They need to be amassing demonstrable outcomes in terms of, elevating their profile in their job interviews. And they also want to do something that's different from their peers because they want to do something that's not mainstream. So we thought, okay, computational biology is great there. And then we asked ourselves, because we want to generate impacts, who will be the beneficiaries? And so we asked ourselves, okay, so many people that really want to work with young undergraduates is organizations like community organizations. So we had our stakeholders there. And then the question was, how can we connect all those stakeholders together and produce something valuable? So after lots of these internal and external analyses, we came up with a model of Virtuome, which is a summer school in digital health that's built on the 3 pillars of computational biology, because that's what we do and are good at, personal development, that's important for the students, and then community impact, that's important, well, for what we're striving to achieve, but that's important also for the organization we're working with. And then we strapped everything together, organized the program around, for the students to contribute to new resources, to have specific outcomes. So there's reports, there's videos, there's lots of presentations. So they have something to show for. and then also with the organizations to do PPI with us and craft the projects together with the students. That's both important to the organization and the students. Like I might highlight, for example, we work with the Irish Migraine Association to find links between potential food triggers of what people eat and having a migraine episode afterwards. So people looked, the students together with the association looked at certain triggers. We looked at, certain motivators of people to drink energy drinks early in the morning. So that was important to some of the students. And we work together with a rare disease organization, the PKA Society in Ireland, to see as well what are the nutritional behaviors in relation to the nutritional recommendations. So sometimes there's a disconnect between what's recommended to you and what you actually eat in everyday life. And what are the motivators and certain barriers of people to adopt certain nutritional profiles. So we brought all of this together, and we now in our 7th year running. So Jadzia and Stacey, our 2 colleagues, they started this week. With the 7th consecutive year, and so far we have 96 alumni and over 2,500 community contributors.
Well, congratulations. That sounds like a very successful and very strategic approach to building involvement from the student side. We talked about patients, we talked about involvement from young scientists and students. Let's talk about clinicians. Do you involve also that group, that stakeholders, and how and what do you see beneficial from the relationship you creating with clinicians?
Yeah, so we do involve clinicians, of course. And to put it in relation, so patients are the end beneficiaries of the technologies, but I think very often clinicians are the end users because they are the ones who are the person in the loop to make the decisions that will benefit the patients in the end. So still looking towards the impact of technologies, clinicians are one of the main stakeholders we need to involve throughout. And for example, different ways of involving clinicians we did in the past was to identify certain conditions, to identify what's important to them in their workflows, and what are potential barriers of using new technologies. And there's a couple of things we've learned. So if you're in a clinical environment, you are also bound by, let's call it the safety operating procedures that are in place. So often the clinical practice is bound by historical data of how fast you can implement new technologies. So that's one thing. So there's a certain bias or a certain barrier we need to overcome with the technologies. The other one is you might have the best technology in the universe. If it's not practical to implement into your daily workflow, they will not use it. So, for example, one thing we're currently working on is on a diagnostic support system for rare diseases called ChatRD, and it's a computer interface where you can input a patient's narrative, and it helps you give you pointers towards potential diagnoses. So one thing we involved clinicians was, well, to test it out and tell us, is this practical in the first place, yes or no? So that's an easy question to ask. And then the second one is, how does it fit into your potential workflow? So that might be something as basic as them telling us, well, I don't like the way your website looks like. So, that's something on the front end we can change. But then sometimes the way the information is ranked or presented might need some adjustment. So that's direct user feedback we might gain. And sometimes, in our development, we might have focus on a certain metric in terms of making a diagnostic decision tree that's maybe not practical in certain situations. So they will specifically tell us on a technical level as well. So that's what you need to do. That's what you need to implement. And that's a potential barrier where I'm more or less likely to use it in the end. So that's kind of the development involvement of clinicians we take in. And then thinking way into the future, I would love to work with clinicians and kind of test out how our technologies might add specific value in whatever shape or form. So we might make faster decisions, better decisions, cheaper decisions. How does that fit into the work process? But I think that's still a while to go until we have that opportunity.
Is there any hospital that is in line with your work, like one specific, or is it your kind of work also to make sure that you involve hospitals and clinicians?
Yeah, so in terms of digital metabolic twins, I think we're still thinking way into the future, but now
Right.
thinking towards maybe Avicenna Alliance, where I have the opportunity
Mhm.
to meet lots of people that are at the forefront at different areas of modeling. One area is Boston Children's Hospital. So we had the Avicenna Days in 2023, where David Hoganson, one of the surgeons, used digital twins of hearts to, well, it's twofold what he does. So on one side, he uses digital twins of hearts to help plan out his surgeries. So he has, based on that digital twin of the heart, he makes decisions in terms of planning with his team to make better, to already be better prepared when you go into the surgery room rather than open somebody's thoracic cavity and then only be presented at the very moment
Sure.
with reality. And on the other side, to also help bring in patients, and very often these patients are children, with their parents to have that conversation about, what are we doing? And have, really, let's call it an educational conversation about, what's the best choices we can make as a collaboration, as a team to help you out in the future. Other people, for example, at the Avicenna Alliance uses VR technologies to, create 3D models of how to make better interventions in the future. So I think there's a lot of opportunities we can have. But coming back again to, say, the healthcare system we often live in, often you need extensive validation until a certain technique becomes mainstream. So on one side, we live off those pioneers who are able to use some of the technologies to make better decisions in their own practice. But that does not necessarily mean that as a community, people will gravitate towards the new technologies we are currently developing in the lab. So there's lots of push and pull in terms of individual pioneers and maybe the healthcare system we're operating in to make those sustainable changes in the future.
Yeah, I can see this model that is very interesting in the States that solutions that need to be validated and tested, they are, if they are interesting to hospital and to a certain group of clinicians, they come to they go through the program of validation. And this allows to, you know, apply this agile approach to change certain features, to understand also the processes, and then you kind of coming from outside, because those models very often are developed by startups, and then allowing this to happen when you can validate and when you can try and test and you've got consultant clinicians that kind of use it and give you feedback. This kind of model of work is really interesting. That also a business model for many hospitals, right? And they make choices which technologies will be validated based on their own criteria. Sometimes this is because they want to have portion of your IP. Sometimes, just pay for the service. But I think this is crucial. And for universities and organizations and startups that do not have their own hospital and cannot do, let's say, organic growth of certain technologies, that is a good way of testing, right? And then making sure that this is something useful. Let's talk about the risks. So we talked a lot about benefits. We talked about the challenges, how to make sure that new models are being useful for the end user and for the beneficiaries. But what do you consider as the greatest risk for this type of technologies?
Yeah, I think there's different risks involved. So one, of course, is any new technology has the risk of, and are we actually doing something better than what is currently available? Because if we just kind of doing the same level, we risking to have a cost issue. So, we essentially spending money in an area that's not spent in another area where it might be more beneficial overall. So that's kind of a very, very basic risk. The other one is always safety. The second you're in a healthcare environment, the question is how safe are the decisions you're taking? So, well, I think there's only a tiny fraction of any new drugs that are being approved that are actually safe throughout. So, whatever you had in the pipeline initially, and even if they go into clinical trials, only a tiny fraction makes it through the end because of safety profiles. I think computational modeling doesn't have those risks, at least not initially, because we are not intervening in an invasive level with the patients. So I think that's a huge opportunity in terms of kind of do risky technology developments without the risk of harming a patient. So I think that's one thing there. And then on the other side, because we are dealing with data, I think there's always the question of representation and bias. To give you an overview, like we do lots of microbiome science, and historically, microbiome research has mainly done in the westernized world. So that's the Europe and the United States, which then means if you have a very different lifestyle, they're very different diets, you might not have the same microbiomes. You might have very different microbes living inside you. And then whatever decisions we are now making based on a very westernized opus of science may not be representative of another area in the world where that's an issue. So, well, I mentioned Apollo, our resource earlier with the 250,000 microbes. I think that's the first resource we've created where the data, microbiome data, came from throughout the world. So this was not focused on sequencing data just in Europe and the States, but was really throughout the entire world. And I think having that data becoming more and more available now and in the coming years, I think people are better equipped nowadays to create computational models that start mitigating the risk of having a geographic bias throughout. I talked about geography and maybe culture. The other one is age. So very often clinical studies have been done on healthy individuals. So let's say they're adults in between 20 and 40. So that means children are underrepresented and elderly people are underrepresented as well. So that's one issue. The other one is sex. So historically, lots of research has been done with only male participants. And then women were underrepresented. And because women were underrepresented, those differences haven't really been addressed. To give you an example, like we created our whole body models now, they have a different model for male and for female. And in terms of metabolism, that makes total sense because male and female have very different organs. They are differently metabolically active, so they have different consequences on your metabolism. So you have to have sex-specific models. And I think that's really starting to become more and more, let's call it mainstream in medicine, sadly only nowadays, because on one side, that diversity has been overlooked historically, but also I think it's a cultural question really on how we've done science. The cliche of the white male who's done the scientific work like 50 years ago has been a reality. And now we're having the consequence of that reality from history. So I think having that awareness now is to what have we learned, what we can do to mitigate those risks, and how can we become more aware now. And I'm pretty sure that maybe scientists in 30 years' time look at us nowadays and say, why have you done it this way? Obviously, that's wrong. But, we always having the benefit of retrospect. So, let's not be judgmental, but let's try and what can we learn and mitigate those risks going forward. And, it's all about mitigation. We can never abolish risks throughout, but I think we can do better in the future for sure.
Yeah, let's stop a little bit on this topic of bias, which is very dear to me. I think that maybe in computational medicine, AI also, not only mechanistic models, not only numerical algorithms, but also neural networks, we need to take it a little bit more seriously, because when we know that there is a bias and we multiply it, and we claim, okay, this is for the benefit of making system more efficient, we amplify what is, as a bias in the data already. And you mentioned children. So I read a few years ago this article, Where Are the Children? And it was actually from archaeology. An archaeologist was asking why we don't have any kind of idea what did the kids do 3,000 years ago. But this occurred to him when he had his own children, and he started seeing the world through their lens. And a very simple solution to that bias was that you lower your eyesight. So you go to the cave, and rather than looking for the paintings here, you go down and then you see the traces of what the kids were doing. And I think that also what you mentioned with children being underrepresented, understudied, it also comes as a bias of the whole system, because this is such a, small group of, let's say, patient and rare diseases who are, for example, spread in this population, are not presenting kind of economic value, not very often. So the incentive also to tackle these problems might be caused by the system itself, right? So it's very dear to me that we're mentioning this. But let's talk how to mitigate this. So you said collecting more diverse data, but that's one step. What else? Then if something comes out from that data as a result, then we need to change the guidelines how to treat diseases, right? And how to use medication.
Yeah, I think that's where we're probably having the opportunity again of public and patient involvement, because there's a disconnect still nowadays in between what's being developed and being predicted or perceived to be valuable to the end user and what really matters to the people themselves. And there was a case study that really struck me in terms of public and patient involvement by a mother who had a child with diabetes, and she said, usually very often people get an insulin pump, and her child who was a 2-year-old got a pump for an adult. So essentially the pump didn't work properly, didn't attach properly. So the pump was way too big and way too heavy for the child who wanted to play. And then because the child needed to wear that pump, it impacted lifestyle because the child wanted to play with her friends. And, there's been lots of issues, and that could be mitigated in the end by essentially collaborating with the medical device manufacturer and, making the device a different shape. So it didn't need to be smaller because the components still need to be fit in, but to distribute the weight differently, and also they use a different glue so it didn't fall off immediately when the child started running. So small adjustments can have a very, very big effect. So, well, that was a long story to tell you. We need to be aware of how the risks manifest in real life. And I think public and patient involvement is a very big opportunity to have those conversations around, what's your experience historically with the old technology, and what are the things you want addressed in the future technologies, so we gain that awareness of potential risks. And then the other one is, I'm always a bit scared by what we don't know. So I think we have to be very observant and open-minded towards creating new metrics and new observables for capturing potential risks we don't know nowadays. And I say that because, for example, when we're building those holistic mechanistic models, we're having genetics, and we're all aware of the risks of genetics overall. So, using the usual like anonymization and not having any personal data attached, and having very strict data handling guidelines, you minimize those genetic risks. But other data like metabolomics or proteomics, they do not have that genetic risk associated, because currently it's impossible to identify a specific person based on, say, their proteomic data alone. However, that changes if you start integrating that data with other data. So maybe a data set that wasn't identifiable nowadays will be identifiable in 10 years' time, just because we're becoming more and more apt of integrating those data. And, there might be only one person in Ireland who's got the same metabolic profile as myself, if you also take into account lifestyle and, heart rate and behavior and all these kind of things. But we don't currently have a metric of assessing this. So there's a little bit of a risk we are getting a feeling for being aware of, but there's no concrete metric. And I'm afraid the risk management bit based on feelings doesn't work. So I think we need to really start adapting our metrics and benchmarks towards future guidelines and practices. So even if they're not actionable right now, let's already start being reflective and noting them down and see how we can mitigate along the process, because by the time the risk has a negative effect, it's already too late. So, we need to start starting to be more forward thinking nowadays already.
Yeah. So what are your plans? What in front of you? What are you now focused on?
Yeah, so there's different things I like to think about. I think in terms of what we're currently doing, would be the vision of using nutrition to help people be more healthy. And I focus on the word healthy because, again, I feel like traditionally people have focused very much on disease, but if we're really preventive and helping people be their best selves in terms of lifestyle and nutrition and so on, to maybe not become sick in the first place or have certain delays or not having a disease severity that would otherwise manifest, that would be very, very important already. So using nutrition in a personalized manner to be the best healthy self would be a very big vision. The other one is in terms of performance as well. So there's one thing about being healthy, but how can you perform the best possible? And that might be, well, of course, if you're a sports person, how can I be the best performing athlete in 3 weeks' time when I have whatever competition coming up? I think that would be very, very interesting of tackling with a metabolic angle in the future. And then thirdly, I think we going into the question of, early diagnosis and prevention of certain conditions, because we're still treating symptoms very often. We're not treating the underlying condition throughout. And how can we really establish that coaching approach we mentioned earlier, rather than going see a healthcare professional once it's too late? How can I use my phone as a coach that tells me you're absolutely fine today, but based on your behavior and based on your recent whatever metrics I've been measuring, I recommend you consider these 3 things. And it's still up to me to choose whether I implement them in the first place and which one I prioritize to maybe implement early on to not have the worst case scenario outcome of becoming sick in the first place. So I think that's something else I'd be very, very interested in tackling.
Well, thank you very much, Cyrille. This was
Well,
amazing.
thank you.